request all the respectable colleagues to settle down so we may start the next session. टाइमर होगा तो फिर क्या इनको पता लग जाएगा? टाइमर चलेगा ना 25 मिनट का. Welcome back. Now we move on to the next session, which is of the peritoneal dialysis. My name is Dr. Muhammad Usman. I am the moderator for this session. I am consultant nephrologist at DHQ Teaching Hospital, Faisalabad. The chairperson for this session is Professor Dr. Khalid Raja Saab, who is the professor of nephrology, and he's pioneers of nephrology in the MH hospital. He is currently working as head of department of nephrology at Military Hospital, Rawalpindi. So, over to you, Khalid Raja Saab.
Assalamu alaikum. I'd like to invite Professor Nisar Anwar, MRCP, FRCP. He is the professor and head of nephrology department at Khyber Teaching Hospital. He is also the ex-president Pakistan Society of Nephrology from 2015 to 2017. Professor Nisar Anwar, please.
Thank you, Mr. Chairman. Assalamu alaikum and a very good morning. PD, some of you had the opportunity to take part in the workshop, and the moderators, they were able to not only clarify the ideas and the practical issues pertaining to PD, but also went through the concepts behind this modality of dialysis. So some of the slides, they may be a repetition of basically what you have already learned. I'll try to basically sort of rush through them, and there are others where we need to dwell for a while and clarify the reasons why this very important modality has not really clicked in our circumstance so far. So we'll try to basically figure out the reasons and come up with some guidelines and recommendations as to how we can utilize or blend this modality with our existing tools. What I want to clarify from the very beginning is that PD is not a competitor to hemodialysis. This should be taken as basically another tool in your armamentarium. So very important that we basically use it in tandem rather than isolation or only for the patients who by default don't go on basically hemodialysis, and therefore only when you have acutely sick patient who is deemed not fit for hemodialysis, or the very elderly and frail, or the very young ones, they are the ones who are basically put on CAPD, and therefore that brings basically a bad name to modality in terms of technique survival. Of course, the goal of any renal replacement therapy is to preserve life. So PD is no different. Our aim is to basically prolong life, and of course to add quality to the life, and to try to basically restore health to the pre-azotemic phase if possible, and also basically make it convenient and conducive to the patient's circumstance. So PD may not be for everybody, but it must be considered as a very important tool that you have in hand when kidneys have failed and you are struggling to stay alive. There is no dispute about basically that treatment is non-inferior to hemodialysis, and this has been established by many of the prospective trials. Peritonitis rates, which were basically a major concern, dampening basically acceptance across the board, they have dropped to almost basically one episode per every 2 to 3 years now. And of course, the prescription-based dialysis, as we learned yesterday during the workshop day before, that has basically settled the issue of transport issues, and we can identify basically the porosity of the peritoneal membrane and accordingly issue a prescription which basically suits the patient depending on whether they have a high transport status or a low one, and accordingly whether they are suitable for CAPD or CCPD based PD treatment. There is almost no risk of viral hepatitis, so transmission of infections is negligible. And of course, we can extend the treatment to the very disadvantaged early kids and elderly patients. Diabetics are a very big chunk of our hemodialysis population today, who have all sorts of problems, including the vascular concerns. They are the most suitable for this modality of treatment.